All right, next up in our Learn to Swim mnemonic is synovial sarcoma. Synovial sarcoma is most common in patients that are in their teens and into their 30s. This is going to really happen at any site, but it can have a predilection for the extremities. And this is a really broad range of histologic features. You're going to see tumors that are very poorly differentiated. You're going to see tumors that are monophasic, that is, they're either only spindle cells or only round cells without an epithelial component. And you'll see biphasic tumors that have spindle or round cell and epithelial elements. The differential here again, I talked about Ewing sarcoma. We'll talk about malignant peripheral nerve sheath tumor because both of those are spindled. Wilms tumor because again, synovial sarcoma can happen in weird places like the kidney. And I think rhabdoid tumor is an important thing to think about too for a couple of reasons that we'll talk about in a second. I think the major update on synovial sarcoma from the last 5 years is that there is now a really, really good immunohistochemical stain. 5 years ago, people were talking about TLE1 and maybe they weren't so excited about it, but people should be really excited about immunohistochemical staining that directly targets the SS18 SSX fusion. Because so far it is incredibly sensitive and incredibly specific. It is actually an antibody that's designed to target the breakpoint in the SS18 SSX protein. So very good sensitivity, very good specificity. CD99, this is another tumor that's going to have some CD99. It's not going to be as strong and diffuse as Ewing sarcoma, but it's going to be there. Cytokeratin, any cytokeratin, I particularly like cytokeratin 7, is going to be positive. It's going to really help you draw out those epithelial elements. And the one reason I mentioned rhabdoid tumor, in addition to the fact that synovial sarcoma can have some rhabdoid cytology, is that synovial sarcoma is actually characterized by a decrease in INI1 in the tumor cells. So SS18 SSX incorporates itself into the SWI/SNF complex that includes INI1, destabilizes that complex, and actually leads to degradation of INI1. So you can actually see by immunohistochemistry these tumors have less INI1 in the tumor cytoplasm compared to surrounding things like the vascular endothelium. Now this is a fusion, again, because that part of the reason that the antibody to the fusion protein is so specific is because that fusion, the SS18 fused either SSX1, SSX2, or SSX4, is essentially definitional of synovial sarcoma. Essentially, every synovial sarcoma you're going to diagnose is going to have one of those fusions, and any presence of those fusions makes something a synovial sarcoma, which is really helpful because, like I said, the histology can be kind of variable. So here's a poorly differentiated example. And you can see low power, looks like a sea of blue. But I should point out here at low power, you can see some of these open, dilated vascular spaces. We call these staghorn hemangioparasitic vessels. That's really characteristic of synovial sarcoma, so that's a good thing to look for at low power. At higher power, this is going to have a really characteristic pattern of this kind of whorled, short curved fascicles. And we have a really nice name for that in pathology. We call that storiform. So you have these short fascicles that are curved and intersecting. They kind of look like a pinwheel. Now the other feature that's here, and this is really hard to see, but there's actually some small things here that have this concretion of debris, if you will. This is actually a very poorly differentiated epithelial element. And if you did, if you did pancytokeratin or CK7 on this tumor, you would see that that really highlights all these epithelial elements that are kind of indistinct in that background of poorly differentiated spindle cells. So here's the immunostain I was talking about. This is straight out of the paper that was in AJSP last year, and you can see that the epithelial component of this biphasic tumor, this more poorly differentiated tumor, both of these pick up the fusion protein in almost all of the tumor cells. So the highlights for synovial sarcoma. You're going to see this at any site in a lot of different ages. It can have a lot of histologic appearances. That hemangioparasitic vascular pattern is super helpful. The fusion is also very helpful because it's essentially definitional. And because the fusion is so common, the immunostain is very, very, very helpful.